Just over the next few, couple of minutes, talk about a few things important about this virus that I'm sure the group is already aware that I call this virus a handicapped virus. It doesn't do much by itself. It really needs the presence of hepatitis B to have a co-infection. So there's no mono-infection with hepatitis D. The general sort of risk factors associated with transmission are similar to hepatitis B, contaminated needles, transfusion, sexual transmission, and the there is a benefit, and it's poorly understood of, and thankfully why the mother to baby transmission is quite low. And then a lot of patients are either asymptomatic or they have vague symptoms. We often see that with viral hepatitis. There's nothing specific that you can highlight. As we'll be talking about in more detail, there's acute or a chronic version of this virus, depending on the how the infection is acquired. And something that you're going to hear over and over in the next 30 minutes is how this virus, in combination with hepatitis B, sort of increases the risk to cirrhosis and cancer development. So very important to start looking for these patients. So a little repetitive, but just to get a little bit more granular in terms of the transmission of this virus, the needle stick, tattooing. Tattooing has become less of an issue in the United States, as most of the tattoo parlors in all the states are so well regulated. But I always ask my patients, do you have tattoos, and where did you get the tattoos from? Within the United States, outside the United States, as we know that not every tattoo parlor across the world is regulated the way it is in the States. So, of course, sexual contact, sharing of drug preparation equipment, all that stuff, contact with contaminated blood. And as I mentioned earlier, the mother-to-child transmission is exceptionally rare. Hepatitis D requires hepatitis B for replication and transmission. So the vertical transmission of Delta can only occur in the context of maternal Hep B infection. And the mechanisms involving the perinatal exposure to both hepatitis B and D, typically during delivery, hepatitis D is not very efficiently transmitted. That's all I can tell you in terms of transmission across the placenta. And I think that's important and a benefit. So it's important that noting that even in maternal patients with high hepatitis B viral load, the presence of active delta replication, the studies have shown that the transmission, the co-transmission is still low. Now, part of that could be that we're doing such a good job following these patients and in third trimester making decisions to treat their or control their hepatitis B viral load so that the risk of hepatitis B transmission drops. But again, it's poorly understood, but duly noted. So who's at risk for having hepatitis Delta infection? Migrants from endemic countries, certainly newborns, infants to infected mothers, but like I said, that's a very, very small subgroup. And the other blood-borne pathways that can transmit the virus, as mentioned before. So, the recent global data highlights that the hepatitis D prevalence is substantially higher in these risk groups, specifically among injection drug users, estimated around like 37-38%, and also pretty high in high sexual behavior, about 17%. So all this is to sort of, when you have the interaction with the patient, the counseling becomes extremely important. So regardless of how the patient gets the virus, I think it's important to note that if they have known hepatitis B chronic infection as the hepatitis B surface antigen positive, these individuals are at risk of being infected with the Delta virus, and then therefore we have to think about every patient with surface antigen positive to be tested for hepatitis D. So the epidemiology. So these numbers keep changing. It's thought that about anywhere from 5 to 14% of hepatitis B surface antigen patients have been exposed to Delta. And that's the average number that's quoted is about 5% of the hepatitis B population, translating to about 10 to 20 million. Again, there are different references. You'll hear anywhere from 12 million, 15 million, but the average is, I would say, about 10 to 20 million people worldwide. And again, there's been more research to understand the true prevalence of this disease. And like I started the talk by saying that initially there wasn't a lot of press on this virus because most people didn't know what to do with it. But as we start looking at therapeutic options down the road, we really need to understand the true prevalence, not just in the globally, but also in individual countries. So there are 8 different genotypes. For those who treat hepatitis C, hepatitis B, genotype does make a difference in terms of clinical impact. And here you can see that the different genotypes from different parts of the world. Genotype 1 is the most widely distributed globally, predominantly found in Europe and in North America. Another comment is like genotype 3 is restricted to the South America, Amazon basin, and actually has been linked to fulminant hepatitis D. Sorry. And if you look at genotype 5 from parts of Africa, it's linked to a little bit more benign clinical course and demonstrates a better response to interferon, the only treatment currently available. And that's comparing genotype 5 to genotype 1 patients. And, the clinical manifestations of these different genotypes vary in terms of their response to therapy, vary genotype by genotype. And in the future, there may be scenarios that for different genotypes, we have different treatments or different algorithms of treatments in terms of length of treatment as we learn more and more about this, how this virus behaves. So as I mentioned earlier, the true prevalence varies from source to source. The migration from endemic regions also contributes to increased hepatitis D prevalence in Western countries, particularly among immigrant populations. And the universal hepatitis B vaccination programs have reduced hepatitis D incidence in some regions that have the hepatitis B vaccination programs, but has not affected the prevalence in those countries that do not have a vaccination program. So, again, a little bit more about the prevalence. The study was done, uh, looking at 25 different countries and looking at the prevalence. And again, the prevalence varies from country to country. No surprise there. The one country that uh, the one country that sort of gets a lot of press in terms of the highest hepatitis D antibody prevalence in amongst surface hepatitis B surface antigen positive individuals is Mongolia. Other countries with high prevalence include like Moldova and then certain parts of Western and Middle Africa. Um, again, these numbers are going to continue to change depending on the quality of the studies, and of course, as more and more countries start showing interest in their population to look for this virus. So I think this is the if you forget everything about my talk, I think this is one thing that shows us how we're doing taking care of Delta patients. If you look at the literature, you can see these cascade slides about hepatitis C, hepatitis B, and it all comes down to how these patients, the infected patients, are being picked up using screening protocols based on the city, the zip code that they live in, or the healthcare system that they interact with. How many of them truly have not just the antibody, but also the PCR positive blood test, meaning have the true disease. And out of those, how many are being managed appropriately, including not just the treatment, which is we're doing a very poor job, but also are they being appropriately monitored in terms of cancer screening? As you can see, we're not doing a very good job. So there's a need. There's a huge unmet need in terms of the affecting this care cascade for the Delta virus, and really need to look at all the limitations from jumping from one bucket to the other, and hoping the difference that we made in the hepatitis C patient population and hepatitis B. And thanks to the hepatitis B ECHO program, where as we educate more and more providers, raise awareness, the screening and linkage to care rates increase over time. And I think that's what we need to do for hepatitis D virus. So a little bit about the virus. So it's a RNA virus, and not to get too technical, but it's actually a very tiny single-stranded circular RNA genome, and it really doesn't do a whole lot. As I mentioned earlier, it's a very sneaky virus. So it has enough genes to make like to encode like replication enzymes or proteins that allow it to bind to the appropriate proteins, specifically hepatitis B surface antigen, and also make delta antigen proteins. And these are all required to obviously replicate this virus. And essentially, if you follow from top to down, the single-stranded circular RNA genome gets incorporated with these different proteins, the hepatitis delta antigen, and they come in different sizes, large and small. And then the final product, is the incorporation or use the hepatitis B surface antigen from the B virus, that's where the handicap is. It cannot make its own, and this is where how it incorporates itself using this surface antigen, and therefore it becomes a functional virus at that point. And once it's functional, basically it uses the appropriate envelope proteins to infect cells, and it enters the cell using this NTCP receptor, and this is how it enters it's a transporter receptor, I should say, and this is how it gains entry into the cells and create havoc. And really, if you start thinking ahead of what my last few slides are going to show, this may be a target of future therapies. In fact, it is, but this is how I like to show these cartoons to just give you an idea that if we can prevent this virus from entering the cell, maybe we can make a difference. So how does the damage occur? So, it's a handicap or a satellite virus, and it requires the hepatitis B surface antigen for its life cycle. And, the pathophysiology of this virus is complex because not only is it very self-centered, I feel like I'm talking like about my older kid, but it's also has the ability to suppress the replication of hepatitis B through mechanisms that we don't understand, and I'll show you some data about that. And this dual infection scenario often leads to more rapid progression of liver disease. As I mentioned earlier, you're going to get sick of me saying that this co-infection gives us more cirrhosis and liver cancer compared to monoinfection of hepatitis B alone. So here is on the left. Also, it has the ability to sort of spread, not just by entering the cell through the transporter receptor that I showed you earlier. That's the most common way, but also as a cell is dividing, it can sort of piggyback through, as shown on the right, it can piggyback through the replication process, and this is where how it duplicates itself from one cell to the other. And again, it's a very evolutionary. This is very sneaky, but creates targets for future therapies. So again, not to belabor the point, but the life cycle of this virus is it gains entry through the NTCP receptor, and then it goes through the different replication process where the virus itself, the genome, starts taking over the factory of the hepatitis B virus, and it starts replicating. And there's one step called prenylation, where the protein gets modified further, and that allows it eventually to exit the cell. And again, highlight a site where future therapy can be provided. So this is essentially how this virus causes damage in the hepatocytes, and then increases the risk for fibrosis given the chronic inflammation that occurs. So, as we sort of look at the behavior of this virus in terms of what the hepatitis D virus is doing versus the B virus, D as in Delta, B as in boy, you could see that there are three observations that have been noted, or three patterns of infection. All the way on the left is the most common scenario where you'll see a pretty significant level of the hepatitis D RNA level, compared to the hepatitis B level is suppressed. It's on the lower end. Again, we don't know why that is, but that's the predominant observation. And every so often, you'll see the middle scenario where both levels are detectable, but they're not super high. And it's rare to see the flip side, which is the Delta virus is low on the lower end, and the B virus is on the high end. So longitudinal studies show that the interaction between these two viruses is I guess dynamic, and with these fluctuating viral loads, but recognizing the first slide, the first cartoon on the left is the most predominant observation or behavior of these two viruses getting along with each other. And again, there's more science to be discovered behind this, and hopefully leading to more cures. So the natural history and the disease progression, this is when we get clinical. So I mentioned in my introduction that this is Delta is a pretty more severe form of viral hepatitis. And on this slide, you see that just the general observations of the 5 different hepatitis that we deal with clinically. And as you can see, what's highlighted in the box, in the red box around the Delta virus, that the risk of cirrhosis is about 70% in 5 to 10 years, and HCCs within 10 years. Now you sort of think about the hepatitis B patient, the monoinfection patient that you see. We see HCC in those patients. In fact, that's why we have algorithms and guidelines to screen them for liver cancer. But their risk for developing cirrhosis and HCC is a lot lower. So again, hepatitis D patients, as you identify them, you need to think of them, put them in a special bucket of how closely you need to monitor them for advancement of their fibrosis, cirrhosis, and certainly liver cancer development. So this is just, again, being repetitive to certainly make the point of how important this is, that the long-term consequences in this viral hepatitis, in comparing the co-infection with the monoinfection and their risks for cirrhosis, liver cancer, liver failure, leading to liver transplant, and certainly mortality, that the co-infected patients, unfortunately, do a lot worse. Now, there are sort of 2 observations in terms of how a patient gets the Delta virus. On the left side of the cartoon is a patient who is getting the hepatitis B and Delta co-infection simultaneously. And these patients either are going to spontaneously clear the virus, and that's the tendency, that's the observation. And a minority of those patients, about 19%, are going to develop chronic infection. And then what follows after that is the cirrhosis and HCC, which is liver cancer. On the right side, you'll see that the patients who get the super infection, meaning they have known hepatitis B virus, and you're following them for years and they're doing fine, and all of a sudden their numbers shoot up. It looks like they're having a flare. You're constantly asking them, are you taking your hepatitis B medication? And maybe they have some high-risk behaviors. And that's when you notice that they have developed a superinfection, meaning the Delta infection is new, that the outcome there is worse. Their increased risk for developing progression of their liver to cirrhosis and liver cancer. So it's sort of important to not say, well, I'm only going to look for the Delta patients. So let me rewind for a second. So the known hepatitis B patients that you have currently, if they've never been checked for Delta, please check them. And for those who are clinically stable, are doing well, if they have a decompensation or any change in their clinical status from a liver standpoint, those are the ones you think about getting, a new super infection, and you should think about Delta virus first. So the co-infection mostly leads to eradication of both agents, whereas the majority of the patients with super infection do worse. Okay. I think I'm going to skip over this slide. It's essentially is saying the same thing in terms of difference between the monoinfection and the co-infection, how the co-infection patients do worse. Now, when we're seeing these patients in the office, what are some of the things they're telling us? They have both viruses. Maybe you're controlling the hepatitis B. Maybe it's undetectable because you have them on antiviral therapy. But based on patient-reported outcomes, without any effective management, these patients are having a lot of vague symptoms, abdominal discomfort. They're constantly worried because you've told them now that they're going to have worsening liver outcomes and liver cancer. So that impacts and increases the anxiety scores. And that really impacts their day-to-day. So it's kind of living in a prison, so to speak. So certainly, if we could do something about that, we all would. And they have challenges. These patients may experience the different challenges that we often see in patients, depending on either socioeconomic or health literacy point of view. But essentially, they did a study on a survey looking at people living with Delta virus and what sort of challenges that they that affect them. And they're listed here. There's a lack of information for patients. They don't have a poor understanding. There's a lack of awareness. Many of them have poor access to healthcare. There's certainly language barrier always creates a curveball. We've noticed that a lot in linkage to care with hepatitis B outreach models across the country. So this is where, again, as you look at this information, it's things to work on back in the clinics where you see these patients, where it starts with providing the right information for these patients so that, and how are we as the clinicians and our outreach partners and the pharmaceutical companies, how are we all coming together in addressing this? I think this is something that we need to continue talking about and I think help is on the way, and it's not all sad news that I'm presenting here. So recommendations and rationale in terms of hepatitis D testing, who to test. Basically, everybody with surface antigen positive hepatitis B, and you would repeat that testing if they have a clinical change in their if they were negative in the past. And the blood test to send for are the anti-hepatitis D antibody. If it's positive, then you should check the RNA, which is the PCR. But a lot of health centers are looking into financial models of how to do reflex testing, like we do with Hep C. We don't even think about it. If someone is positive antibody, they get a reflex viral load for the PCR, and if it's positive, you go ahead and start treating those patients. I think we should do the same for hepatitis D, and there's a lot of interest in this. Again, we just have to rally as many people, including labs who would take this on, like big labs like LabCorp and Quest and all these places, along with health center labs. There are some New York City health systems that have started to do this, specifically Mount Sinai Medical Center. So in terms of our report card of how we're doing in terms of screening, I'm asking you guys to screen, but how have we done in the past? And as you can see in this study, looking at different clinics out of the UK and then comparing it to some of the centers in the US in categories, there's some centers are doing an excellent job in terms of checking for the Delta virus, and then there are those who should be listening to this talk. So I think we can all do better, but recognizing the importance of why we have to recognize these the virus earlier on and monitor these patients before we can start treating them. All right, let's get to the meat and potatoes of the talk. I should be done in the next few minutes. I know I'm running a little behind, but I think this is exciting. So the management. So up until this point, all we had was interferon. And for those who've either heard of it or used it on patients in the past, pegylated interferon from the time period when I used to treat hepatitis C patients was never fun. It was never fun for the patient. It was never fun for the doctor. 80% of our patients would have symptoms, whether it's neuropsychiatric symptoms, cytopenias, just feeling crappy. And it's for 48 weeks, right? So this is not like take 2 of these and call me in the morning. This is for a long period of time. So the compliance for interferon and the appetite for interferon is not great. So looking at this life cycle cartoon, similar to what I've showed you, where there is entry of the virus into the cell, and then replication begins, and then they make more virions, and then they get packaged and they get released. They're different places where different molecules are in different phases of research to see if we can provide a cure or a control of this disease. The first one would be what I alluded to earlier on, which is, can we prevent this virus from entering the cell? And the answer to that question was bulevirtide. It's entry inhibitor, blocks that receptor that I was talking about. Doesn't do much for hepatitis B, but has been shown in preclinical trials, phase 1, phase 2, that it does a good job lowering the hepatitis D viral load. And again, it's pretty effective, but it doesn't do anything for the B virus. And based on phase 1, phase 2 studies, there was a phase 3 study done, presented and published in New England Journal of Medicine in 2023, and basically showing that the patients, there were about 150 patients. who had chronic hepatitis B, and their hepatitis B was all controlled with antiviral therapy. They all had hepatitis D, obviously, and they were put on either bulevirtide 10 milligrams or 2 milligram dosing, or compared to delayed introduction. And basically, they had enough cirrhotic in these patient population. So it was a pretty good study, and this showed that at 48 weeks, the 2 milligram dosing and the 10 milligram dosing, there was a good reduction in their viral load, what they called a combined response, which is their liver tests improved, and there was a 2 log drop in their hepatitis D viral load, which was at 48 weeks. And when they followed it to 96 weeks, you had a further drop in their viral load. Couple of things to note about this molecule. It's a sub-Q injection. It has to be given daily. So think about your diabetic patients who need to take insulin. They're not very fond of that, although there's been a lot of modification made in the insulin delivery, those pens where you just have to change the needle. But the company is going to have to, it's going to be a challenge. It's currently available in Europe, but currently, as alluded to earlier, Gilead has this molecule and is trying to bring it to market after hopefully FDA approval. So because and it's well tolerated and it's safe, the investigators sort of pushed the envelope and said, well, if one drug can do a good job, why don't we combine it with interferon and then see what happens? And this is another New England Journal paper based on combination of pegylated interferon with bulevirtide, and they did different dosing of bulevirtide and the absence and presence of interferon. And if you look at the purple slides, not hard to believe that patients at 96 weeks who got bulevirtide and pegylated interferon did quite well. But again, in this study, because again, it says that the peg interferon was well tolerated, it's hard for me to believe. I'm not knocking peg interferon. It's just that it's nobody's, in the past, hasn't been anybody's cup of tea. But this is something important to note, that this may be an option in the future, especially for patients who are not elderly or who don't have too many comorbid conditions and are able to tolerate interferon. So this, again, these drugs are, the bulevirtide is not available in the United States, but is with the FDA for review. So, and it's safe. And then what I'll do is just looking at this roadmap to all the different molecules that are being studied at this time. I'll just say a general comment that people are really taking this research seriously, and between monoclonal antibodies and other entry blockers and prenylation inhibitor that didn't do really well in clinical trials, that all these different molecules are in different phases of trial, trying to come up with an eventual cocktail, either a combination or single agent that maybe helping cure the hepatitis B from these patients. But most of these are not ready for prime time for me to spend another hour talking about them. But what thoughts should I leave behind? So regardless of patient background or characteristics, as I mentioned, the hepatitis B patients, think about Delta virus, screen them, and then monitor them to see if they develop Delta at a later date, if they have a clinical worsening of disease. The prevalence is still being worked on. The more data that we have, the more information is helpful from a public health standpoint in taking care of the population. So we need to do more work on that. Um, we delineated the difference of co-infection with superinfection, that the superinfection patients are the ones who are going to be sicker. So be mindful in looking for them. The co-infection patients don't do well long term. So think about cancer screening, think about their quality of life, start talking to them about, hey, there's treatment on the way, hang in there. Hopefully in the next year or two, we should be able to offer them something. And this sort of summarizes what I already said. Liver cancer screening. There are a few papers now that are talking about hepatitis B surface antigen measurement. In one of the interferon studies, the combination bulevirtide and interferon, there was actually loss of surface antigen, meaning the hepatitis B, there was a functional cure. So it's important to note that as we get newer drugs, we will be following these patients differently. So it's important to stay up to date with what's coming. And then the last slide is get your patients in a trial, those you think that cannot wait. I went on the clinical trials website and just put in, basically filtered through only United States trial, and they were like over, I think, 30 places that popped up across the country. So you do have access to drugs. And the last thing I'll say is bulevirtide, because it's not FDA approved yet, it's still available for compassionate use for patients who you feel are really struggling. There are very strict criteria with Gilead. You can reach out to them. I do have one patient who's on his 4th month. Gilead was very generous in giving him the drug, and the patient is doing fantastic. He's just accustomed to the fact that he has to give himself a shot every day. And yeah, so I will stop here. Thank you so much for your attention. And if there's any question that I could try to answer, that'd be my pleasure. Thank you.
Thank you so much. That was a very comprehensive overview of Delta, and I also appreciated the updates on current treatment pathways. So that was very helpful. Just flagging that I put in the chat the 2 reference New England Journal of Medicine publications that were discussed, as well as some specific coding for labs like Quest and LabCorp to order the Delta testing. One question that did come up, which I think is really important, from one of our participants is that is insurance covering the Delta testing? I wonder if you could, Dr. Kalia, if you could help answer that.
Yes, I mean, it's standard of care. We have not had any pushback. We in the New York area, I would say 80% of the time use our own Northwell Core Labs, where I think it's still a send out test for either Quest or LabCorp. I don't know exactly, but I could tell you that the patients haven't gotten any bills. And for the 20% of patients who go to LabCorp and Quest directly, again, as long as you have the right codes, I don't think there's been any problem. This is standard of care.
Great, thank you. And again, I did put a link to the codes for both Quest and LabCorp and a couple of other labs that are in the US, and available in the chat as well. So I hope that that will be a helpful reference for folks. Um, you mentioned earlier on in your presentation counseling with Delta patients. I wonder if you have any recommendations to providers who may encounter a Delta patient, how tips for communication and strategies for kind of sharing that information and giving them an overview of what Delta looks like and what their care journey might look like.
I think that's so important. Thank you for that question. What I do is I think very visually, and you could tell that from my slides. So I that's how I counsel patients. I often I have a computer open in front of me. I will show the picture of the liver journey that occurs from a normal liver. If you Google liver fibrosis progression, there are like 1,000 pictures in there. And I pick one and I'll tell them that what are the risk factors for that person having liver disease. Uh, and something I didn't bring up in my talk is besides having hepatitis B and Delta virus, alcohol is being used by many. It's a legal drug, and so is in terms of obesity. A lot of patients are walking around with metabolic syndrome and fatty liver. So there are a lot of sort of insults in the liver that are progressing a normal liver to cirrhosis. But to highlight the Delta virus, I tell them just like the drinking needs to stop and the weight needs to be lost. At this time, they may not be a great candidate for interferon, but let me do a fibrosis assessment with the FibroScan. Let me see whether how often we need to screen you for liver cancer. Let me tell you what this virus is doing inside of you and what we're planning to do for you in the near and far future. I get very granular in terms of I understand this is upsetting you. I know you're worried, you're young, and you may die of cancer, but this is why it may be earlier on, it may be good to get a hepatologist at a transplant center involved, at least as a check-in. I have this patient, and there's nothing, it's everything's stable at this point, but I'm worried he may develop cancer. So I think all those conversations, which by the way takes a lot of time, but is so important, as shown by those surveys, that if a patient walks out of your office scared, one, they may not come back. And we've seen that with hepatitis B. So, but if you empower them and you tell them that we're going to work on this together. You do your part, and I will monitor you. I think the response, the outlook is better, and yeah, and I think it's just being frank that right now I don't have anything for you, but we went through this for hepatitis C, we went through this with hepatitis B. Delta treatment is on its way. Start creating lists of the patients who you will readily start writing prescriptions or readily start referring to hepatologists and gastroenterologists with Delta virus as soon as treatment becomes available. You may even want to get an opinion before the FDA approves it. So that's why for my patient, since I got him on treatment earlier this year, but the process started late last year. It was a lengthy process to get the compassionate care for with Gilead. But yeah, that's a drawn out answer, but I'm very passionate about them walking out of my office empowered and not feeling scared.
Thank you. I think that's a really important point. Thinking about the empowerment side from the patient perspective, I think that's really great. We had a comment in the chat as well. Thank you for your excellent presentation. I'm from Ethiopia. I think we have a couple of providers from Ethiopia on the call today. I think there's no testing for Delta, even if it's very common, and even if hepatitis B is very common as well. Any thoughts or maybe recommendations for folks in low and middle income countries where Delta may be common, but we're not really sure? We know the burden of Hep B is common, but again, testing is a real challenge.
Yeah, I mean that's a human question. That is how certain countries have amazing resources and unfortunately a lot of waste. I mean, look at the amount of testing that we do in our clinics just so that we don't feel like we're going to get sued, as opposed to countries where, you could save a month's salary to say, well, I can only get one test done. Which one should the doctor tell me I should do? I'm passionate about public health, but I don't know if I have strategies. I think it starts with that one person who wants to make a difference, and then through philanthropy, through getting government to start paying for this. A lot of these countries, unfortunately, don't have good public health sort of setup where, or if they do, they don't even have resources to address them. But I think it starts with ideas from wealthy countries, and then if the clinicians are traveling back, you just have to get the like-minded people under one roof and then start brainstorming. I know I'm not giving a clear answer because I don't know, but we had a similar issue uh, in terms of concept. How do we in the Bronx, when I was in a different health center, how do we approach patients from West Africa who are dispersed? They go to different mosques and different churches. How do we engage with them to at least raise awareness about getting tested for hepatitis B? And it started with just telling them about the disease and then getting grants from Gilead and other companies and saying, okay, can you help us link them to care? And then getting patient assistance program to pay for the drug. Again, and many of those patients weren't insured. But again, even if we made a difference in one patient, I feel we made a difference. But again, when you talk about a huge population where the prevalence is so high, that's why we see young people in their 20s and 30s arriving in the US with large cancers. It's already too late by then. So I know I'm not providing a lot of answers, but I think it starts with somebody passionate on the bottom of the food chain and somebody in the government or someone with the pocketbook saying, this is important. We need to do this for our people.
Yeah, thank you. I think there's really just a lot of work overall to be done around hepatitis delta, both in the US and globally, improving access to testing and just improving testing for those that are positive for hepatitis B. So I think that that point of impacting one patient can make a really big difference, and it spirals from there in a positive way, hopefully. But I think we had some other feedback, most just positive comments about the presentation and how helpful it was. So just want to take a minute to again appreciate you, Dr. Kalia, for coming in today and speaking to us about Delta. I think this was a really helpful overview, and I think we learned a lot from this session. So just appreciate you taking the time and looking forward to hopefully having you on more echo sessions and engaged and connecting us with other providers so we can continue to make impactful change and share knowledge around hepatitis B and Delta. So
No,
thank you.
thank you, Catherine, and thank you, everybody. And I hope, we all go back charged with good information to help our patients. And I had a lot of fun doing this. Thank you for the invitation. And of course, if you call on me, I'll show up and would love to. Yeah, I do miss the days where we actually met in person.
Yes.
But at least the virtual forum it's a lot more flexible, but this is good. As long as the information gets out there, that's all I care about. But thank you again. This was a lot of fun and hopefully very soon we can start talking about the actual treatments and how to treat these patients and plug them into clinics so that we can get rid of this virus.
Definitely. Thank you so much. And thanks again. And thanks to everybody who joined the session today. Again, as you exit, there will be a survey. If you could fill it out and provide some feedback to us, that would be great. And again, our next session will be in October. You'll see that through the iEcho platform, and we'll be focusing on liver cancer since it is Liver Cancer Awareness Month. So thanks everybody again, and I hope you have a great rest of your week.
Bye-bye.
Bye. Thanks everybody.